Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 240 of our pharmacotherapy series, which majors in endocarditis. The first question reads, PAG, a 57-year-old, 60-kilogram man with chief complaints of fatigue, a persistent low-grade fever, night sweats, arthralgias, and a 7-kilogram unintentional weight loss, is admitted to the hospital for evaluation. Visual inspection reveals a cachectic, ill-appearing man in no acute distress. Physical examination is significant for a grade 3-4 diastolic murmur with mitral regurgitation, that is insufficiency, increased from pre-existing murmur, a temperature of 100.5 degrees Fahrenheit, petechial skin lesions, subingual splinter hemorrhages, and Janeway lesions on the soles of both feet. Nail clubbing, Roth spots, or Osler nodes are not evident. The remainder of his physical examination is unremarkable. PAG's medical history is significant for mitral valve prolapse and, more recently, a dental procedure involving the extraction of 4 wisdom teeth. The history of his present illness is noteworthy for the development of symptoms 2 weeks after the dental procedure, about 2 months before admission. His only current medication is ibuprofen 600 mg orally 4 times a day. Relevant laboratory results include the following. Hemoglobin of 11.4 grams per deciliter, that is in SI units 114 grams per liter. The normal range is 140 to 180 grams per liter. Hematocrit of 34%. The SI units, 0.34. The normal range is 0.39 to 0.49. Reticulocyte count, 0.5%. The SI units are 0.005. The normal range is 0.001 to 0.024. White blood cell count of 35,000 per microliter with 65% polys and 1% bands. The SI units are 35 times 10 per liter with 0.65 polys and 0.01 bands. The normal range is 3.2 to 9.8 with 0.54 to 0.62 polys and 0.03 to 0.05 bands. Blood urea nitrogen of 21 mg per deciliter. The SI units are 7.5 millimoles per liter of urea. The normal range is 2.9 to 8.9. Serum creatinine of 1.2 mg per deciliter. The SI units are 159 millimoles per liter. The normal range is 53 to 133. A urinalysis reveals 2+ proteinuria and 10 to 20 red blood cells per high-power field. The erythrocyte sedimentation rate is elevated at 66 mm per hour. The normal range is equal to or below 30 mm per hour, and the rheumatoid factor is positive. Results from a transthoracic echocardiogram were unrevealing. 3 blood cultures were obtained during 24 hours, and all cultures obtained on day 1 air-growing gram-positive cocci in pairs and chains, presumed alpha hemolytic streptococci. Although conformation and speciation of the organism is being performed, PAG is started on penicillin G, 2 million units IV every 4 hours, that is 12 million units per day, and IV gentamicin, 120 mg loading dose, followed by 60 mg every 12 hours. Antimicrobial susceptibility results are pending. What clinical manifestations and laboratory abnormalities in PAG are consistent with infective endocarditis? The clinical presentation of infective endocarditis is highly variable and can involve almost any organ system. PAG appears pale and chronically ill, and represents the typical patient with subacute disease, e.g., that caused by viridin streptococci. Nonspecific complaints consistent with endocarditis in PAG include fatigue, weight loss, fever, night sweats, and arthralgias. Fever alone is present in most, that is 90%, patients with endocarditis. The fever is characteristically low-grade and remittent, with peaks in the afternoon and evening. Fever may be absent or minimal in patients with congestive heart failure, chronic renal and liver failure, prior use of antimicrobial agents, or infective endocarditis caused by less virulent organisms. Musculoskeletal complaints, e.g., arthralgias, myalgias, and back pain, are common and may mimic rheumatic disease. Other symptoms can include lethargy, anorexia, malaise, nausea, and vomiting. Because signs and symptoms are nonspecific and subtle, diagnosis is often difficult to make. In addition, the time from bacteremia to diagnosis is often prolonged because of the insidious progression of symptoms. Delayed diagnosis occurs more commonly in the elderly. Fever may be absent in 30% to 40% of patients older than 60 years of age, whereas it can be present in more than 90% of patients younger than 40 years of age. Elderly patients are less likely to have new or changed heart murmurs. The most common presenting complaints in the elderly with endocarditis are confusion, anorexia, fatigue, and weakness, which may be readily attributable to stroke, heart failure, or syncope. The temporal relationship between PAG's dental procedure and the onset of symptoms suggests it was the etiology of bacteremia and subsequent endocarditis. Although it is assumed that prophylactic antibiotics were administered before the procedure, endocarditis can develop despite receipt of adequate chemoprophylaxis. PAG has an increase in his pre-existing diastolic murmur with mitral insufficiency, a finding consistent with endocarditis. Cardiac murmurs are present in more than 85% of patients with endocarditis. Murmurs frequently are absent in patients with acute disease, e.g., staphylococcal endocarditis, right-sided disease, e.g., endocarditis in IV drug users, or mural infection. PAG exhibits several peripheral manifestations of infective endocarditis, including conjunctival petechiae, Janeway lesions, and splinter hemorrhages. Overall, peripheral manifestations are observed in 10% to 50% of cases, but none of these is pathognomonic for infective endocarditis. These manifestations are usually a result of septic embolization of vegetations to distal sites, or immune complex deposition. Mucocutaneous petechial lesions of the conjunctiva, mouth, or pharynx are present in 20% to 40% of patients, especially those with long-standing disease. These lesions generally are small, non-tender, and hemorrhagic in appearance, and occur as a result of vasculitis or peripheral embolization. Janeway lesions are painless, hemorrhagic, macular plaques most commonly found on the palms and soles. Splinter hemorrhages are nonspecific findings that appear as red to brown linear streaks in the proximal portion of the fingers or toenails. Other findings can include Roth spots, that is small, flame-shaped retinal hemorrhages with pale white centers found near the optic nerve, and Osler nodes, that is purplish, non-hemorrhagic, painful nodules that develop on the subcutaneous pads of the fingers and toes or on palms and soles. Clubbing, that is broadening and thickening, of the nails also may be observed in patients with prolonged disease. Petechial skin lesions also are seen. Several laboratory findings are consistent with infective endocarditis in PAG. A low hemoglobin and hematocrit with normal red cell indices suggest anemia of chronic disease. Of patients with subacute disease, 70% to 90% will have a normochromic, normocytic anemia. Leukocytosis with a left shift, although not evident in PAG, commonly is seen in those with acute, fulminant disease such as Staphylococcal endocarditis. The ESR nearly always is elevated in infective endocarditis, but this finding is nonspecific and can be associated with several other disease entities. RF, an immunoglobulin M antiglobulin, and circulating immune complexes can be detected in most patients with long-standing disease, but both are nonspecific findings. Major embolic episodes and infarction involving the kidney, spleen, lung, and brain may develop as secondary complications in up to 1/3 of cases. PAG exhibits some degree of renal damage, as evidenced by moderate hematuria and proteinuria. Alterations in PAG's renal function, that is increased BUN and creatinine, probably are a result of immune complex deposition, that is diffuse glomerulonephritis, or secondary to renal embolization, that is focal glomerulonephritis. Erythrocyte and leukocyte cast formation also may be present. Renal impairment usually is reversible with the institution of effective antimicrobial therapy. Cardiac complications occur most frequently. Congestive heart failure from infection-induced valvular damage is the most common cause of death in infective endocarditis and is the most common indication for surgery. As many as 2/3 of patients with endocarditis develop congestive heart failure. Aortic valve infection is more frequently associated with congestive heart failure than mitral valve infection. Other manifestations include paravalvular abscesses, pulmonary edema, and pericarditis. Mitral valve injury caused by viridin streptococci generally is better tolerated hemodynamically than aortic valve injury caused by staphylococci. Although PAG has no apparent signs of overt heart failure, he should be monitored closely for the development of hemodynamic instability. Neurologic complications, most commonly stroke, rank second to cardiac complications in frequency, but they may be the leading cause of death in patients with endocarditis. A stroke syndrome in a patient with underlying valvular abnormalities should prompt the clinician to rule out infective endocarditis. Other clinical manifestations include headache, mental status change, transient ischemic attack, seizures, brain abscess, or intracranial mycotic aneurysms. Neurologic symptoms associated with high mortality can be observed in up to 35% of Staphylococcus aureus endocarditis patients who are not drug addicts. Metastatic abscesses can develop in virtually any organ secondary to systemic septic embolization. The most commonly involved metastatic foci are the spleen, kidney, liver, and iliac and mesenteric arteries. Splenomegaly, although not part of PAG's findings, occurs in 20% to 60% of all cases and is more common in subacute disease. The next question reads, how was the diagnosis of infective endocarditis established in PAG? We will first consider blood cultures. Although PAG's medical history, that is mitral valve prolapse, recent dental procedure, and clinical presentation are highly suggestive of infective endocarditis, blood culture is the single most important diagnostic workup for infective endocarditis. Bacteremia, when present, secondary to endocarditis, is continuous and low-grade. More than 50% of the cultures show only 1 to 30 bacteria per milliliter. Despite the low concentration of organisms, at least one of the first 2 blood cultures is positive in 95% of cases. In order to achieve a high yield, at least 3 sets of blood cultures collected by separate venipunctures should be obtained during the first 24 hours of presentation. Administration of antibiotics within the previous 2 weeks may significantly decrease this yield. It is also important to establish the exact microbiologic cause before initiating antimicrobial therapy. In patients who are acutely ill, empiric therapy should start as soon as the appropriate cultures are obtained to avoid further valvular damage or other complications. We will now look at echocardiography. Echocardiography is a valuable tool in establishing early diagnosis, e.g., the presence and size of vegetations, identifying patients at high risk for complications, and optimizing the timing and mode of surgical intervention by detecting and monitoring associated pathologic changes such as valvular abscess. The transducer may be placed on the chest, transthoracic echocardiogram abbreviated as TTE, or in the esophagus, Trans-Esophageal Echocardiogram abbreviated as TEE. TTE is a rapid and non-invasive procedure with 98% specificity for vegetations. Sensitivity for vegetations may be less than 60% to 70%, however, for adult patients with obesity, hyperinflated lungs caused by emphysema, or a prosthetic valve. TEE is more costly and invasive, but is significantly more sensitive in detecting vegetations while maintaining high specificity. All patients with suspected infective endocarditis should have echocardiography on admission and repeated during their course, to help guide future medical management and timing of intervention. In particular, compared with TTE, TEE is superior in the diagnosis of pacemaker infective endocarditis and infective endocarditis in the elderly. PAG has a negative TTE result on admission. Given the high clinical suspicion for infective endocarditis in PAG, a follow-up TEE is recommended to rule out a false negative TTE result. In summary, infective endocarditis should be suspected in any patient who has a documented fever and heart murmur and a preceding risk of bacteremia. Prior cardiac disease, peripheral manifestations, splenomegaly, various laboratory abnormalities, and a positive echocardiogram strengthen the diagnosis, but microbiologic documentation is the most important factor in confirming infective endocarditis. Disease entities with overlapping clinical presentation and laboratory abnormalities should be excluded using the appropriate tests. Based on published evidence involving nearly 2,000 patients, the 2015 AHA guidelines suggest that the modified Duke criteria be used as the primary diagnostic schema to evaluate patients suspected of infective endocarditis. PAG possesses one major criterion, that is positive blood cultures, and 3 minor criteria, such as fever, predisposing heart condition, vascular and immunologic phenomena. Therefore, he meets the diagnostic criteria for definite infective endocarditis. My next questions to you read: what would be a reasonable duration of antibiotic therapy for PAG? When is determination of minimum bactericidal concentration useful in treating bacterial endocarditis? The avascular nature of the vegetation results in an environment that is devoid of normal host defenses, e.g., phagocytic cells and complement. This permits uninhibited growth of bacteria. Therefore, to eradicate the causative organism, high doses of an IV bactericidal antibiotic generally are administered for 4 to 6 weeks. For some infections, it may be necessary to use 2 antibiotics to achieve synergistic activity against the organism. Once an organism has been identified, its in vitro susceptibility pattern is determined by the minimum inhibitory concentration for various antibiotics. Standard Kirby-Bauer disc diffusion testing is inadequate in the setting of infective endocarditis to aid in selection of antibiotics without the quantitative information provided by the MIC. In addition, the MBC may be useful in detecting tolerant strains, particularly in the setting of unexplained slow response or treatment failure. Routine MBC determination is not recommended, however. Treatment of endocarditis requires antibiotics with bactericidal activity, therefore, the serum concentration of the antibiotic must greatly exceed the MBC for the particular organism. For endocarditis caused by viridans streptococci acquired from the community, this usually is achieved without much difficulty because most isolates are sensitive to penicillin at an MIC of less than 0.12 micrograms per milliliter. Corresponding MBCs are, at most, 1 or 2 tube dilutions higher. The emergence of strains demonstrating resistance to penicillin and related beta-lactams, such as ceftriaxone, is a significant problem, particularly among bloodstream isolates obtained from the nosocomial setting and neutropenic cancer patients. The increasing prevalence of beta-lactam-resistant clinical isolates highlights the importance of determining the MIC and continued close monitoring of the antibiotic susceptibility of viridans streptococci. An increasing number of reports have described suboptimal response to vancomycin therapy for the treatment of invasive infection caused by methicillin-resistant Staphylococcus aureus (MRSA) strains showing borderline susceptibility (MIC 2 micrograms per milliliter). Many such strains demonstrated tolerance to vancomycin as defined by a high MBC to MIC ratio equal to or above 32. Thus, these data support the need to determine MBC, especially in the setting in which the treatment option for infective endocarditis caused by Staphylococcus aureus is limited to vancomycin and suboptimal response is observed. My next questions to you are, what factors must be considered in selecting a regimen for PAG? Which regimen should be used for PAG? Patients with endocarditis caused by penicillin-sensitive strains of viridans streptococci and nonenterococcal group D streptococci, e.g., Streptococcus galliticus with an MIC below 0.1 micrograms per milliliter can be treated with any one of 3 regimens as outlined in the 2015 AHA treatment guidelines. The suggested regimens are associated with cure rates of up to 98% and include a. High-dose parenteral penicillin for 4 weeks. B. High-dose parenteral ceftriaxone for 4 weeks, and C. 2 weeks of combined therapy with high-dose parenteral penicillin and an aminoglycoside. Ceftriaxone with an aminoglycoside for 2 weeks appears to be equally effective. Next we will consider the use of high-dose penicillin for 4 weeks. 10 to 20 million units per day of IV penicillin G for 4 weeks resulted in a cure rate of 100% for 66 patients with nonenterococcal streptococcal endocarditis. Another study using penicillin monotherapy reported relapse in only 2 of 49 patients, however, both of these patients received less than 4 weeks of therapy. The large range of 12 to 18 million units per day of penicillin is recommended to allow flexibility in dosing based on the patient's renal function and disease severity. Ampicillin 2 grams every 4 hours is a reasonable alternative. Next we will look at single daily ceftriaxone for 4 weeks. Ceftriaxone is active against viridans streptococcal strains isolated from patients with endocarditis. In one study, all 49 strains of Viridin streptococci and 11 strains of Streptococcus bovis were inhibited at less than 0.125 mcg per milliliter of ceftriaxone. One strain of Streptococcus sanguinis was inhibited at an MIC of 0.25 microgram per milliliter. Although no direct comparative trials have been performed evaluating ceftriaxone against high-dose penicillin for the treatment of streptococcal endocarditis, it appears to be comparable to high-dose penicillin when treatment is given for 4 weeks. Of the 70 accessible patients who received ceftriaxone 2 grams as a single daily dose for 4 weeks, all were cured, except for one patient who had a probable relapse 3 months after completion of therapy. All strains of Viridin streptococci were inhibited by ceftriaxone at an MIC of 0.25 microgram per milliliter in both studies. Although the simplicity of single daily treatment with ceftriaxone is attractive for outpatient use, careful patient selection based on microbiologic, clinical, and host factors is critical to the success of treatment and the proper and timely management of potential complications. Next we will look at high-dose penicillin or ceftriaxone plus an aminoglycoside for 2 weeks. The combination of 2 weeks of streptomycin or gentamicin with 4 weeks of penicillin is synergistically bactericidal for most streptococci, including enterococci. This in vitro synergy also has been correlated with a more rapid rate of eradication of Viridin streptococci from cardiac vegetations in the rabbit model. A shortened combination regimen consisting of high-dose penicillin G and streptomycin for 2 weeks is an effective alternative to the previously described regimens. The reported cure rate in 104 patients treated at the Mayo Clinic with this regimen was 99%. Although clinical experience with combination therapy has been primarily with penicillin and streptomycin, in vitro and animal data support that streptomycin and gentamicin are reasonably interchangeable. Administration of gentamicin once daily versus thrice daily when added to penicillin appears equally effective in the treatment of Viridin streptococcal endocarditis. Combination therapy with ceftriaxone and aminoglycoside for 2 weeks has also been evaluated. Clinical cure rates of 87% to 96% were observed in patients infected with penicillin-susceptible streptococci when given once daily ceftriaxone 2 grams plus netilmazine or gentamicin at 3 mg per kilogram. This study excluded patients with suspected or documented cardiac or extracardiac abscesses and those with PVE. Although the aminoglycoside agent netilmazine or gentamicin was administered as a single daily dose in both studies, all of the patients had measurable serum trough levels. Therefore, the efficacy of extended interval dosing of aminoglycoside, whereby trough levels are not detectable, allowing a drug-free interval in short-course combination therapy remains uncertain. Based on available data, the 2-week regimen of penicillin or ceftriaxone plus an aminoglycoside appears to be efficacious for uncomplicated cases of penicillin-susceptible Viridin streptococci endocarditis. It is not currently recommended for patients with extracardiac complications or intracardiac abscesses. Patients infected with Abiotrophia species, formerly known as nutritionally variant Viridin streptococci, or Viridin streptococci with a penicillin MIC greater than 0.1 microgram per milliliter, or patients who have prosthetic valve infections should not receive short-course therapy. We will now look at special considerations. The risk of relapse may be higher in patients who have had symptoms for more than 3 months before the initiation of treatment. These patients should be treated with 4 to 6 weeks of penicillin combined with an aminoglycoside for the first 2 weeks. nutritionally deficient or variant Streptococci (NVS) have been reclassified into a new genus, Abiotrophia, which includes Abiotrophia defectiva, Abiotrophia adiacens, renamed again as Granulocartella adiacens, and Abiotrophia elegans. Abiotrophia species are slow-growing, fastidious organisms that are responsible for approximately 5% of infective endocarditis cases. Previously, NVS were the cause of most of the cases of endocarditis diagnosed as culture negative, initially owing to its requirement for the addition of vitamin B6, that is pyridoxal hydrochloride, to the culture media for laboratory growth. Laboratory identification is no longer a significant problem, however, because of current culture media and laboratory techniques. NVS are less susceptible to penicillin when compared with other streptococci. Many NVS have a relatively high MIC to penicillin, that is 0.2 to 2.0 micrograms per milliliter, and some show high-level resistance to penicillin MIC above 4 micrograms per milliliter. In addition, tolerance to penicillin has been described in many strains. An animal model of endocarditis indicates that a penicillin aminoglycoside, that is streptomycin or gentamicin combination, is significantly better than penicillin alone in reducing bacterial counts. High rates of bacteriologic failure and relapse may be expected in patients despite completion of the treatment course for strains highly susceptible to penicillin. All patients infected with NVS or abiotrophia should receive 4 to 6 weeks of high-dose penicillin or ampicillin in combination with gentamicin. A 6-week course of combination therapy with penicillin and gentamicin is recommended for patients with symptoms longer than 3 months in duration and those with PVE caused by these strains. Patients with endocarditis caused by relatively resistant viridans streptococci with penicillin MIC of greater than 0.5 microgram per milliliter or enterococci should receive a similar treatment regimen, as described above. Patients allergic to beta-lactams should receive vancomycin 30 mg per kilogram per day divided into 2 doses for 4 to 6 weeks. Although the addition of an aminoglycoside to vancomycin enhances bactericidal activity in vitro, it is unknown whether the addition of an aminoglycoside confers any additional clinical benefit. Assuming the viridans streptococci isolated from PAG are not resistant to penicillin and he has no other complicating factors, any of the suggested regimens would be appropriate. Because no compelling reason exists to use the 4-week regimens, the 2-week penicillin aminoglycoside regimen could be the optimal choice. Although PAG has mild renal impairment, this is most likely secondary to the endocarditis and should improve once adequate antimicrobial therapy has been instituted. PAG was begun on 12 million units per day of penicillin G, which would be reasonable for his age and mild renal impairment. If nephrotoxicity were a major concern in PAG, penicillin or ceftriaxone alone for 4 weeks is reasonable. If gentamicin is used, PAG's renal function should be monitored and the dose should be adjusted appropriately if not using a single daily regimen. Multiple aminoglycoside dosing requires frequent monitoring for signs of toxicity by taking periodic peak and trough aminoglycoside concentrations. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 241.